and as folks trickle in, some more, a reminder that this particular webinar will be recorded. It'll be a bit before it's available, but it'll be recorded. Welcome everyone to the today's webinar. My name is Ariane Tehrani. I am the founding co-director of the University of California Center for Climate Health and Equity, or CCHE, and a professor in the Department of Medicine at the UCSF School of Medicine. The mission of our center is to harness the expertise and leadership of the health sector to drive ambitious climate action for health and health action for climate. The center is based at UCSF and spans all 10 University of California campuses and 5 healthcare systems with over 100 affiliated faculty. Today's webinar is co-sponsored by the UCSF Academic Senate Committee on Sustainability. As I mentioned earlier, a recording of today's session will be available on our YouTube channel within a few weeks, and you can view all of our recordings of past webinars at the link that'll be in the chat. Now, for today's webinars, we are very excited to have our fellows from our inaugural cohort of the CCHE Decarbonization Fellowship showcasing their projects. The Clinical Decarbonization Fellowship accepts fellows from across the University of California system with an interest in helping address the almost 10% of domestic greenhouse gas emissions responsible for climate change. The University of California aims to reduce its climate footprint. It's been a focus of its efforts over the past number of years, and implementing climate action through decarbonization and emissions mitigation efforts in healthcare requires healthcare-specific solutions and also engagement and leadership from clinicians who are at the forefront of healthcare delivery. And so really to support climate action in health systems, CCHE launched a fellowship to support clinician faculty from all University of California health campuses to apply for the fellowship that's focused on decarbonization and building resilience plans at our UC hospitals. It's my pleasure to now announce today's speakers. We're going to start with Dr. Christine James, who is an allergist immunologist at UC San Diego Health. She's focused on finding ways to reduce the carbon impact of her subspecialty across both inpatient and outpatient settings. She will be presenting her work, Breathing Better, Reducing MDI Use in Healthcare Systems. So we'll start with Christine. Welcome.
Hi, everyone. Thank you all so much for being here. Oh, hold on a second. Let me just go ahead and share. Okay, so hopefully everyone can see. As was said, the focus of my project was on reducing meter dose inhaler use in healthcare. So to give everyone just some background, inhalers are a key contributor to greenhouse gas emissions, not often recognized, though I do think it's gaining some prominence now. And a big part of that really comes from the propellants that you find in those meter dose inhalers in comparison to dry powder inhalers, because they do contain hydrofluorocarbon propellants that actually trap heat 1,000 to 3,000 times, as well as carbon dioxide. And they actually account for almost 3 million metric tons of carbon dioxide emissions. And unlike MDIs, DPIs don't actually contain those propellants. So their emissions actually come out to be 20% lower than MDIs. And one of the reasons why I did focus on this is the fact that this is actually a high priority elective measure for the Agency for Healthcare Quality and Research. And it's pretty important because 34 million Americans have chronic lung disease. So this is something that we need to focus on. So with my original project, I was trying to look at, is there a way to change the prescribing behavior in terms of using DPIs as our long-acting inhalers? Now, here were kind of the pitfalls that came with this original project, right? So when you are doing asthma care, our GINA guidelines have actually switched to SMART. So SMART stands for Single Maintenance and Rescue Therapy. And part of the reason why this was done is because it streamlines that in your inhaler therapies to one inhaler really to use. And with that one inhaler, you can actually see better relief and you have less severe attacks. But here's the thing. The inhalers that they want us to use are meter dose inhalers. So Symbicort and Dulera are the two big ones. So obviously, in terms of care, you're trying to balance following the guidelines, but also thinking about carbon emissions. Another barrier was the fact that, looking at formularies and figuring out insurance coverage, some of this is related to the fact that some insurance companies they like the MDIs versus DPIs, and it's interesting though because at the VA in 2021 they actually changed their formulary to DPIs, but of course I also practice at UCSD, so there's a lot of variation there. And then the third aspect of this is kind of the ease of use for DPIs. So it was interesting because Alex Rabin, who's a pulmonary critical care physician at the University of Michigan, he looked at the change of at the VA when they switched from MDIs to DPIs, and initially he found that this is great. Only 14% of patients have had to switch back to MDIs, and it really hasn't been an issue. But then he actually did a to try to figure out, well, with this switch, what have the health outcomes looked like? And what he actually found was that you did see an increase in asthma exacerbations and going to the hospital for asthma exacerbations when DPIs were getting used. So there's also that balance as well for patients. What is easier to use. So I actually adjusted my project after a lecture that Dr. Cheesebro gave, where he said, you know what, there are smaller things that you can do to try to address this. And one of the big areas that he pointed out was actually looking at our rescue inhalers, so our short-acting beta agonists, because they actually comprise over 50% of our total inhaler emissions. And something that he pointed out was the fact that the brands of albuterol, they vary in grams, not because of the actual amount of medication that can get delivered, but it's more about the amount of propellant. And so you could see this when you were comparing, for example, Proventil versus Ventolin. So what I decided to do was think about, well, if we try to target albuterol, maybe we can make a bigger difference there. So one of the things that I did was I, tried to look at this prescribing pattern in basically our allergy immunology clinic. So I looked at the EPIC order to see what that looks like. And basically what that showed was it just gives you the different albuterol inhalers that you can prescribe and the amount of grams for each one, but it doesn't, and even though it does tell you this is the number of actuations that you can get out of each one, it's not actually really highlighted. So a lot of people, don't necessarily realize what that size really corresponds to. And so then what I did was also use the splicer dicer function in EPIC to look at what are our numbers of inhalers that we've prescribed over a 6-month period, and what are the different types. And then the other aspect of this was the fact that my fellow physicians were not really aware of this issue. So I actually gave a 45-minute lecture during one of our division meetings on this. And prior to the lecture, I did have them take a survey to figure out, well, what's your awareness? And then what I did afterward, with the pre-survey, it turns out that they were actually prescribing Ventolin, which has a greater amount of the propellant, 50 to 60% of the time. And then 6 months later, I actually did a survey, and basically what I found was that 70 to 80% of them were actually now prescribing Preventil over Venolin after realizing what those grams really correspond to. Now, I'm actually able to get more granular data now because in the last month, we actually just got an IRB approval that allows us to look at all of our patients and, data related to their treatments since January of 2000. So now I'm actually working with a colleague to actually use the registry to get, again, that more granular data to analyze that prescription change. Let's see. And then, I kind of just was thinking about a SWOT analysis, of this project. So, you know, some of the strengths of this project for me was realizing that, again, if you start small, you can still get some pretty significant benefits because, for example, Preventil in comparison to Venolin has, a significantly less propellant emissions in comparison. And then the fact that I was able to actually bring this topic and educate my fellow providers so that they could understand that was pretty helpful. And then in addition, looking for the opportunities here, there are different things we can do, like adjusting the epic order and really looking at other departments, seeing what they are prescribing. Now, of course, there are some weaknesses. Trying to adjust that epic order is pretty difficult because it's a long process. And then, of course, with some of the threats with that, looking at, will this take attention away from long-acting inhalers and patient awareness? Now, in terms of scaling up, these are just a few of the thoughts that I had in terms of, having a committee that looks at UC in general, providing education to other clinicians, creating that epic alert that could be applied to the whole system. And then, of course, is there a way to do the survey that I did and really expand it out to see what people know, what the gaps in knowledge are, and, can we make a change on that front? And then more recently, what I've done is actually also, we are trying to figure out a way that we can try to reduce our albuterol use with our pulmonary function testing in terms of not having to reuse multiple albuterol inhalers. So this is something that I'm working on with our pulmonary function test team that we've just started the process of, but this was actually based on a project that Alex Rabin implemented at the VA. And then just some additional projects would be looking at that PFT protocol at the VA, also looking at our inhaler prescriptions at our VA allergy clinic and looking at asthma control there in comparison to the UCSD clinic. And then also a project that I'm doing with AstraZeneca and Sanofi, looking at the sustainability effects of using biologics for severe asthma. So all of this has kind of really expanded out into a few different things. And that is the end. So thank you so much. And I'll let you take over, Ariane.
Thanks, Christine. That was a great summary of what was an incredible amount of work over the course of the fellowship. And for folks, we will do Q&A towards the end. So please go ahead and place your Q&A. You can even ask your clarifying questions at that stage. And so with that, I welcome Dr. Meghna Gadgil, who is an associate professor of medicine at UCSF with a joint faculty appointment at the UC Berkeley School of Public Health. She is an academic hospitalist at Zuckerberg San Francisco General, and her work focuses on health system resilience and climate-related vulnerability. She is an award-winning educator who teaches courses at UCSF and UC Berkeley on human-centered design, health policy, diet and chronic disease, and climate resilience. Dr. Gadgil has been recognized with induction into the UCSF Academy of Medical Educators as a New Voices Fellow with the National Academies of Sciences, Engineering, and Medicine, and a Fellow of both the Society of Hospital Medicine and the American College of Physicians. Today, she will be presenting her project from the fellowship, which was reducing disposable PPE use with data-driven contact precautions for select drug-resistant organisms. Welcome, Meghna.
Thank you so much for that warm introduction, Ariane. Thank you, everybody, for attending. I'm really grateful to have this opportunity to share my work with you. Let me get my screen here. Are you able to see my screen?
Yes, we are.
Okay, wonderful. So I'll be talking today about my fellowship project, which was on reducing disposable PPE use on MDROs from contact precautions. So quick background, I'll be very quick on this. As we already discussed, healthcare contributions to climate change are significant. And in the United States, we're about 8.5% of total national emissions, a quarter of the global health sector. And the majority of these emissions come from scope 3, so supply chain goods and services, including single-use disposable plastics. Petrochemicals in healthcare and plastics in general are pervasive, and the production, refinement, manufacture, transport, and disposal of these plastics has important health equity and environmental justice concerns, but at every step, they also emit greenhouse gases. And now, of course, there's emerging research on the potential threat of pernicious microplastics. Now, let's step over to universal contact precautions. Contact precautions for MRSA, which is methicillin-resistant Staph aureus, VRE, which is vancomycin-resistant Enterococcus, and ESBL are routinely used in most health systems. Just for MRSA and VRE alone, 1 out of 4 hospitalized patients on any day in the United States could be on isolation. And some of this is driven by state and federal regulations that require or recommend contact precautions for MDROs. There's a California Senate Bill 1058, there are VA mandates, and there are guidelines from the CDC, IDSA, and SHEA. But there has been a growing body of work that shows that contact precautions may actually have little benefit. They seem to have little to no impact on transmission rates. This is a highlight of the titles of a number of papers showing this. And there's strong evidence from large healthcare organizations that have used more evidence-driven contact precautions that they have not seen an increase in transmission. At the same time, contact precautions also seem to cause significant harm. They result in longer hospital stays for patients because patients have delays in admission and discharge and delays in diagnostics and testing. They result in more adverse events for patients like falls. They reduce patient and clinician interactions and contribute to patient depression and anxiety. Overall, patients on isolation who are discharged are more likely to be readmitted. And the net output is that you have higher costs for health systems, increased waste, health disparities, and climate impact. So for my project, I was curious about how we might move toward more evidence-driven contact precautions. Now, there's a recent survey published last year that showed that roughly 35% of facilities no longer use routine contact precautions for patients colonized or infected with MRSA or VRE. And this is a pretty significant change from 2015, which was when a similar survey showed only 7% of facilities had more updated contact precautions. So there has been progress. But that said, most early adopters are large academic medical centers, and it's easy to understand why. There's more robust infection prevention infrastructure. Much of the research infrastructure that's publishing the papers, generating this evidence are in big AMCs, and they often put a lot of effort into making sure hospital flow through the ER to discharge and so forth is well managed. And so while this is great progress, most hospital care in the United States and in California is actually in community hospitals, 85%. And so I really wanted to focus on how community hospitals might think about adopting more data-driven contact precautions. So I focus on the 9 Bay Area counties, which are quite heterogeneous in terms of size, socioeconomic status, public health departments, the governance and oversight of the public hospitals there, what data they have access to, and which staff might be responsible for infection prevention and control. I also, somewhat later in the project, ended up including Kaiser Permanente. Kaiser Permanente in California has a total of 40 hospitals, of which 25 are in the Northern California region. They also have a single infection control policy that governs all 25 of the Northern California hospitals, which is an interesting way to potentially leverage rapid change. And then I looked at the UC Health, which is, of course, in California with 6 major academic centers. This is just a quick summary. What I just want to highlight here is that what I found is the majority of county hospitals were using contact precautions, universal contact precautions for MRSA, VRE, and ESBL, with a couple of exceptions. San Francisco County is one, and Santa Clara County is another. And in contrast, UC Health, with again a few exceptions, the Children's Hospital and UC Irvine, does not use universal contact precautions. And this illustrates what we had seen before with the academic medical center and community center, community hospital disparity. I also conducted a huge number of structured interviews with staff across different community hospitals, with infection control, clinicians, policymakers, to try to understand what were the main barriers and frameworks that were driving some of the lack of progress toward moving toward an evidence-based infection control. And I wanted to share these 6 large themes that emerged. The first was regulatory environment. There was a perception that the regulatory landscape really prioritizes rigid compliance over evidence-driven flexibility, and it generated a culture of fear. And there was a shift in the last 5 to 10 years that many people noted from expert judgment to a checklist approach to infection control that made community hospitals less likely to move toward more complex infection control or more nuanced infection control strategies. And then regulatory resistance, however, could be overcome in certain instances through data-driven advocacy. In terms of research and evidence, several community hospitals cited that they felt they were unique and that the evidence in the literature did not apply to them because they were not academic medical centers. They felt that their context, their patient population, and even the building layout was different from what the evidence was based on, and so it didn't apply. And meanwhile, there were unpublished success stories from reduced contact precautions in community hospitals that were not published. And then there were resource constraints and data silos in county hospitals that created a paradox where hospitals can't prove it's safe to move toward more evidence-based contact precautions without first actually reducing them, which they felt they couldn't do. In terms of safety, there was also a perceived safety risk for both patients and staff and clinicians that reducing universal contact precautions might expose people to more infectious disease. In terms of healthcare sustainability, there was a pernicious and pervasive sense that quality healthcare was constantly in conflict with environmental sustainability. And in general, there's a perception, and that was reinforced by other interview data, that there's low environmental literacy in healthcare and the impacts of healthcare on the environment. And this inertia and this lack of education resulted in continued wasteful practices. In terms of culture change, it became evident from speaking and looking through these interview data that the policy and regulatory changes would have to occur before practice could change at community hospitals. Many felt that they couldn't change their practices unless they had the shield of having clear policy support to do so. And that the frontline cultural transformation of the clinicians and nurses would have to follow such a policy change, but not precede it. And then finally, in terms of care delivery, many people echoed what has also been shown in the literature. Their perception was that universal contact precautions did result in worse patient care and it led to systemic bottlenecks in their health systems, fewer clinical visits, delayed response times for patients, and then they reported that there were negative impacts on hospital finances and hospital flow, with downstream impacts for the whole health system when patients were on isolation. In addition to trying to understand perspectives through this qualitative research, I also wanted to look at what the true quantitative impact of contact precautions might be, in case there might be a persuasive narrative there. And I looked at 3 different domains. The first was financial. Excess length of stay for patients on contact precautions worked out to roughly $11,000 per admission. And the additional cost of contact precautions per day, this is just gowns and materials, is about $156 a day, not including staff time. Meanwhile, I also looked at CO2 equivalents to understand the cost just from CO2 from the non-woven disposable gowns that are often used, and then also from the length of stay. And then finally, I calculated the social cost of carbon, which is a US OMB metric. I'm going to skip this slide, but this basically shows the details of how I got to those numbers. And I wanted to show you 2 illustrative examples. Alameda County here in the East Bay has 3 hospitals, roughly 600 beds and 15,000 admits per year. And based on these back of the envelope calculations, these are based on data from the literature, so I don't have their real numbers, but we're looking at roughly $49 million a year spent on universal contact precautions. And the CO2 estimate and the social cost of carbon as well were non-trivial. And then let's look at Kaiser, where we have 21 hospitals spread out over the Northern California region. The financial impacts of the roughly 180,000 admits they have per year resulted in almost $570 million in terms of the cost for contact precautions. Similarly, their CO2 estimate was 10 million kilograms of CO2 equivalents a year and $2 million in the social cost of carbon impact estimate. So in brief, I wanted to actually close with a discussion of new directions and paradigms in discussing contact precautions and infection control writ large. The first is that We have new paradigms in disease transmission in the last few years. A lot of these were started during the COVID pandemic, and they've really started to gain steam. The first is that there's a shift away from airborne, droplet, and contact precautions toward a understanding of the touch spectrum and the air spectrum, with, of course, that Venn diagram having some overlap in the middle for things like monkeypox. And when we think about the touch spectrum, we're talking about biofilm and fomite transmission, with the healthcare environment as a continuous touch opportunity. And that means that the treatment for that would be continuous disinfection through visible spectrum light or self-disinfecting surfaces that might be impregnated with copper, for instance. And in the air spectrum, the inhalational paradigm applies. So we're talking about small and large particles, both being potential culprits in transmission of disease. And so the treatment for that would be ventilation and universal masking. And in neither of these is universal gowning going to be playing a role. And on top of these new paradigms in transmission, we're also looking at new paradigms in infection control. So the vertical traditional paradigm looked at focusing on specific organisms. So MRSA, VRE, ESBL, through active surveillance, that means swabbing patients when they come in to see if they might be colonized. And the goal was to isolate carriers and infected patients. And that certainly can be useful in emerging pathogens or in an outbreak. But the horizontal prevention paradigm is slowly taking root. And that shows that it's more cost effective and has a more broad impact, in part because it targets all healthcare associated infections. It's about universal decolonization with daily chlorhexidine bathing, for instance, for select patients. There is hand hygiene, of course, is an important cornerstone of this kind of care. Standard precautions, but only for select tasks where staff might be exposed to body fluids, and then environmental cleaning. And I think that there are really good opportunities here to not only think about how we treat how we use contact precautions for MRSA and VRE and ESBL, but also how we might think about different use of our resources and more judicious use for things like COVID as well. So I'm happy to take questions. Thank you so much for your time.
Thanks, Meghna. And there are a lot of questions actually pouring in, but let's go to Naomi next, and then we'll come back to questions for the entire group, because I am seeing some questions that have a bit of overlap that I think all of you would want to respond to at once. And so with that, I welcome Dr. Naomi Hauser, who is an infectious disease and infection prevention physician at UC Davis Health. Her focus is on resource stewardship to improve patient care and decrease healthcare's environmental impact. And today she's going to be discussing her project, which was leveraging diagnostic stewardship for emissions reduction, urinalysis, and culture. Welcome, Naomi.
Thank you. Okay. Okay, so this project has evolved over time, so I'm gonna kind of start from the beginning here. So diagnostic stewardship is something that I've realized a lot of people aren't familiar with. If they don't specifically work in that area of infection prevention or antibiotic stewardship. So I just wanted to outline what that is. And it's a focus on appropriate and judicious testing to reduce diagnostic error and unnecessary antibiotic exposure while improving patient care. And there's diagnostic stewardship outside of infectious disease and infection prevention. So antibiotic exposure was what I focused on, but it could be other types of medications. And the way I'm looking at it also is as one potential method of decreasing our environmental impact. And my focus for this project has been on urinalyses and urine cultures because this is something we see everywhere in healthcare. And we know that at least 50% of urinalyses and urine cultures that are ordered are probably unnecessary. We also know that about 50% of people who are prescribed antibiotics for positive urine culture don't need treatment at all. And so this is just another area where we're creating waste that we didn't need to. And 95% of antibiotics prescribed for positive urine cultures are prescribed inappropriately in some way. So either too long or too short or the wrong antibiotic or the wrong mode of delivery. And then overtreating asymptomatic bacteria accounts for 17% of antibiotic overprescribing. So that's overall, which is a lot of antibiotic overprescribing. And for patients in the hospital or outside of the hospital, but this is really something we see a lot inside the hospital, is asymptomatic bacteria increases by 3 to 5% for every day that a Foley remains in place. So the longer you leave one in place, eventually you're guaranteed to find bacteria in that urine, and it often gets treated unnecessarily. And something we know is that Scope 3 emissions make up about 80% of healthcare emissions. And most of the healthcare associated Scope 3 emissions come from the purchase, transportation, and disposal of purchased goods. And that includes all of this stuff we're buying, transporting, and disposing of when we do these unnecessary urinalyses, urine cultures, and administer these antibiotics. So diagnostic stewardship potentially can decrease urine culture waste, hospital CAUTI rates, and antibiotic exposure. So the aim of my overall project was to identify areas for urinalysis and culture stewardship. And so this project has been ongoing, like I said, for a few years now and has kind of expanded over time. And something that is consistent over the different years and different projects in this area is separating between appropriate and inappropriate urine culture ordering. And so on the left here, you can see appropriate indications for ordering, and on the right, you can see inappropriate indications for ordering. So I started in 2022 working with a medical student and a resident doing this graduate medical education project looking at outpatient urine cultures processed in our UC Davis labs. And we had a 1-week period in March 2021 that we looked at over 500 urine cultures that were processed. And we worked with the microbiology lab to estimate the number of culture and susceptibility plates with their weights, the collection cup weights, and biohazard bags. And we estimated that this number of urine cultures being processed comes out to between 1 and 200 kilograms of waste over just the 1-week study period, which is equivalent to about at least 5,000 plastic water bottles. And when you know that about 50% of these urinalyses and cultures were unnecessary, this is a lot of unnecessary waste. And this doesn't even account for the other lab resources and the antibiotics that patients would have gotten unnecessarily. So then for this CCHE Fellowship study, I wanted to look at inpatient urine cultures in our ICUs because that's really where I worked most closely through my role in infection prevention. So we looked at a 1-month period, August 2023, and found 59 urine cultures performed on adult patients in our ICUs. And using the same numbers that we used for the outpatient cultures, we found a total waste of about 1 to 5 kilograms of waste for the 22% of people whose urine cultures we determined to be inappropriately ordered, which is about 5 kilos of excess waste per month. And this is equivalent to about 250 plastic water bottles or driving a car 100 miles. And remember, this is just inpatient ICUs over 1 month. So what I really wanted to do with this project was not just calculate the numbers, but I wanted to expand it, and I wanted to bring this to our infection prevention committee and bring it to the different CQI meetings of all the different service lines. So I worked with one of our infection prevention analysts to do a retrospective review of urine cultures in all of our UC Davis ED and inpatient units and look at our urine culture ordering practices. And then we also wanted to look at the indications for orders that were associated with CAUTIs because we thought this might be more impactful. So we had a year of urinalysis and urine culture ordering. And over that year, there were over 23,000 tests ordered. And UACII stands for urinalysis with culture if indicated. So just looking at the most clearly not indicated order reason, which was urine with smell, cloudiness, or sediment, we found 186 orders over this time. And this is this is an order that I think is pretty well known for the most part. And on our order indication panel, the order comes with a disclaimer that says, I know this is not an indication for your analysis with culture, but I'm ordering it anyway, even though I know it's wasteful. And it still clicked 186 times. So we broke down the units that we saw this order. And what we've been doing is going to the CQI meetings of the different service lines and presenting their service line specific data and trying to re-educate everyone on indications for orders. So when we looked at the excess waste of these urinalyses and cultures, we found that there were about 623 kilos of waste for the 23,000 collections, which is equivalent to about 31 million plastic water bottles over the year. And then among just the patients with catheters, there were 35 patients out of 205 that did not have an indication for a urine culture. And based on prior studies, we know about half of these patients probably had no indication at all. So that's even if you cut this number in half, that's still about 15 million plastic water bottles of waste, not including all of the excess microbiology lab waste and the antibiotic waste that comes along with it. So what we've been doing and what we want to continue to do is re-educate providers on the indications for urine cultures. And so far, they've been very welcoming. And I think something that I would love to do is provide service lines with their waste data along with HAI data. Because I have met providers who really never thought about their waste data before, and it's been really influential in kind of their more conscientious ordering. Something that's going to be a little bit harder is combating the pan culture that we see, especially in ICUs, especially I think at academic centers. And then lastly, which is something I'm pushing for, I don't want to say I'm expecting, but I'm hopeful that eventually we'll have FTE allocated for diagnostic stewardship at different hospitals around the country. And that's it. Thank you.
Thanks, Naomi. And so I'm going to ask everybody to come back on video. I see a few questions, and I think I'm just going to actually ask them in order. And I think the first two are for Christine, which are focused on albuterol. So the first one is, my albuterol has a mouthpiece cap that says no CFCs. Can you comment on that and substituting this type of MDI?
So here's the thing. So the only albuterol inhaler that I know of that wouldn't have propellant in it would be the ProAir Respiclick. So I'm not sure if the one that you have is actually a DPI. And the thing is that, again, this is really dependent on what is covered for a patient or what is on the formulary that's offered in certain hospital systems. But because again, I can say that for me, when I've tried to prescribe ProAir DPI, like it doesn't, a lot of times I'm not able to do that, right? And so again, for that, what I do try to do is then just pick Proventil, and at least that way I know that I'm somehow again addressing the need for albuterol while also addressing the higher emissions that can be associated with some of those other albuterol brands.
That's great. Thank you. And then I think the other question for you also is, Christine, what do you think payers or health insurance can do to help regarding inhalers? That is, include more MDI alternatives on a formulary. So just that's just sort of an example, but what are your thoughts on what payers can do?
Yeah, certainly. I mean, I think a big part of that is when they're negotiating those contracts, right, with manufacturers. And so it would be great to have more of those alternatives. Um, I think other aspects of this are really, you know, utilizing our, who try to figure out what do you include on those formularies and if they can provide real world evidence of the fact that, hey, DPIs can be really effective. And so then you can offer more of that on your formulary. But again, I think it really comes back to, you know, how do insurance companies negotiate those contracts, and what kind of information do they need? How are they evaluating what goes on that formulary, and then taking a look at that process and seeing, are there other aspects that we can consider, rather than what they're doing currently.
Mhm. That's great. Thank you. Uh, for the next question is from Meghana. How did you calculate excessive length of stay for contact precautions? The infection prevention world would point out the significant morbidity, mortality, LOS to transmission.
Thank you so much. That's a great question. So the transmission question, you're absolutely correct. If there were increased transmission with the absence of universal contact precautions, then those patients who are getting new infections they would not have gotten would certainly be in the hospital for a longer length of time and significantly have morbidity and possibly mortality associated therewith. And there have been a number of studies that I can cite, but I'm happy to discuss also offline with you if you don't mind messaging me. That have demonstrated no increase in transmission. Meanwhile, there have been very good data showing average increase in length of stay. And the way I calculated for the purposes of the cost calculations for the health systems I described was that the data shows of length of stay increases somewhere between 2 to 3 days for patients who are on isolation. And so I used an average of 2.5 days. And then I used data from average cost of hospital day in California. It's actually higher in the Bay Area than it is in other parts of California, but I use the average number. And that's how I calculated the cost for the excess length of stay. But to your point, the excess length of stay is based on patients on isolation. And then there are very good data suggesting that there is no increased transmission without universal contact precautions. That said, there's still obviously a role for contact precautions in patients where maybe there's active diarrhea or a large wound, and there's going to be a lot of body fluids that will be potentially contaminating different surfaces and the clothing and hands of staff. So I think that this is really more about judicious use of contact precautions and not necessarily about eliminating them altogether. But for patients who might just be colonized with MRSA, but coming in with a URI, maybe they don't need to be on contact precautions.
Great, thank you. This is a question for the entire team. Can you speak to what the main barriers are to scale or have been to scaling up your projects in your clinical setting and or other settings across the UC system as you think about barriers? If you actually could also recommend what could facilitate the uptake of these practices, please tack that on as well because we want to make sure it's actionable. And maybe Naomi, we can start with you.
Yeah. So I think like the main thing that we all struggle with is having the time to pursue these projects. So that's something that's difficult. We at UC Davis, we actually had for a short time a diagnostic stewardship working group that we no longer have because of funding. So it's something that we just kind of have to find time around. Another thing is you really have to establish relationships with the ordering providers. So like in infectious disease, we really don't do any inpatient ordering. And so through infection prevention, we do a lot of monitoring and analysis. So we have to really establish relationships with other service lines that do a lot of ordering before we can come in and talk to them about more appropriate indications for ordering. And that takes a lot of time and coordinating, especially when you're working with surgeons who maybe have a completely different schedule than you have. So that's a big issue, but we're making progress.
That's great. Thank you. I think, Meghna, we'll go to you. What are your thoughts? And I'm happy to repeat the question, barriers to scaling up your projects in the clinical setting. And what do you think could facilitate the uptake of these practices?
Yeah, in my project's case, I would say that UC is not the UC system wouldn't be the target audience necessarily. But in terms of barriers to uptake, I have what was only modestly, and that's maybe being generous, successful, was trying to actually share some of the impact that I had calculated, especially the financial impacts with the folks at some of these community hospitals. And like I described in some of the data I showed, the preponderance of evidence suggests that having a policy that is more explicitly amenable to enabling a more evidence-driven contact precautions in community hospital would be ideal if we could do something at the California level. I think that it may be challenging federally, but it'd be interesting to see if we could explore that at a state level. And the other potential forward-moving pathway would be, and I have some inroads at Kaiser, but I'm still working there, is that they have 25 hospitals and a single policy. And I think that working with their sustainability team and maybe finding a way to make a really persuasive financial argument for them, and they actually have a pretty robust infection prevention and control unit. It's a single unit that surveys all their hospitals, is my understanding, would potentially give us a lot of community level data that would be, that the other community hospitals might be receptive to. So I think those are probably the two pathways, which is starting with a large community system like Kaiser, or trying to think about policy at the state level.
Very interesting. And Christine, what are your thoughts on that question?
I think for me, part of the issue really comes from provider and patient education and awareness. I mean, that's one big aspect of it because as I said, we have guidelines for how we treat a lot of these respiratory diseases. And unfortunately, some of those guidelines don't actually coincide with wanting to reduce those emissions because, by virtue of the inhalers that are recommended. And then, of course, for patients, you really want to focus on their care and how they're feeling. And a lot of times they really do have trouble using those DPIs. Now, if there was time to teach them, I think that you could probably make some significant differences there. But then we're also looking at the fact that, even our clinic visits are so short. And in the UK, when they actually switched, their whole formulary now for patients 12 and older, they really emphasize, the DPIs. That's what they have instead of MDIs. But they also engaged in a very robust education effort. And obviously their system is very different there. I think, another aspect of this is that, again, when you have a healthcare system where you have a bunch of different payers involved, they can, make their own decisions based on their bottom line, right? And even though we can try to influence them with this information, I think they're still focused on that bottom line. I mean, it's why, for example, with the VA, they were able to make that switch to DPIs. So, I think that there are quite a few barriers. I don't think that they're insurmountable in a lot of respects, but they do require a lot of time and effort. And to Naomi's point, it's finding the time to be able to do that as well.
Thank you. And actually, well, one more question, and then I think we're going to close out. As clinicians, aside from the projects that you selected, what other wasteful practices do you see that you would want to tackle next, based on what you've learned on the fellowship, with the aim of reducing emissions and costs without compromising clinical care? And Christine, since I think you are in motion, maybe we'll start with you first, because I know you have to be in patient care in a minute.
So I actually, in addition to this, I'm looking at penicillin testing. So we have quite a bit of waste that comes from when we do skin testing, and it's actually not necessarily indicated in a lot of different respects. And so we can actually just go straight to doing what we call oral challenges, where basically people take the pill and we watch them and make sure that they do okay. But by taking out this whole other aspect, one, it's reducing the waste. You have a lot of cost savings because you don't have to buy all of the materials related to that, and also the charge for the patient is less because you're not using as much time. And by taking off this whole other section, they're again they the cost of all of that is taken away. So that's actually a project that I'm working on with one of my colleagues who has a ton of interest in antibiotic stewardship and really addressing antibiotic allergies. So that's actually again just another way to try to figure out what can I do in this subspecialty to reduce our carbon footprint as a field.
Mm-hmm. Thank you, Naomi.
Yeah, so a lot of my ongoing projects right now are related to diagnostic stewardship and infectious disease in multiple ways. So there's the urine cultures. There's also blood culture issues going on where we had the blood culture bottle shortage that kind of showed everyone that maybe we don't need to do so many blood cultures because we got by with so many fewer bottles. There's also a lot of broad spectrum PCR testing that we do now that's probably unnecessary. It's a good idea in theory to get diagnosis fast, but it's not so good when all the tests come back negative and it's not clinically helpful. And Another thing that I've been working on is trying to engage with the infectious disease pharmacists to work on IV to PO conversion of inpatient antibiotics, as well as liquid to tablet conversion of PO antibiotics, especially in pediatrics. So there's lots. Oh, and the other thing that I should probably talk to Megan about is we're also working on reducing our gown use at our hospital. Because as Megan mentioned, the different UCs don't really have a universal policy for our isolation. And we there are some tests reflex to certain types of isolation that may not be necessary. And different UCs do different screening, which requires different types of isolation as well. And so we're hoping to reduce our gown use and then potentially move toward reusable gowns.
Great, thank you. And Meghna.
Thank you so much. I know we only have about 1 minute. I alluded to this actually in the last couple of slides of my talk, because I think that there is an opportunity here to think about infection control with two new paradigms as have been emerging in the last in recent years. So first is thinking much more about horizontal transmission prevention and not necessarily disease-specific transmission prevention, of course, with certain exceptions. And also thinking more about, if we're thinking about infection transmission as air spectrum and touch spectrum, then what we need to do for each of those different types of agents will be really different. And I think that really introduces the possibility, for instance, of reducing or eliminating the use of gowns and fomite transmission concerns for COVID, where a lot of hospitals still require gowning for patients who might be COVID positive. But it's pretty persuasive that that would be an air spectrum kind of concern. So I think there are opportunities there.
That's great. Well, thank you all very, very much. Welcome, we're glad all of you could attend today, attendees and speakers alike. This is our very first speaker series with the Senate for 2026. Our next one will be in March. And for those of you who are interested, look forward to announcement on that. And thank you again.
Thank you.
Thank you.
Thank you so much.